when we think about immunotherapy, ultimately what we're trying to do is turn on T cells to attack cancer cells. And there's different ways that you can do that. The way that's the most natural, if you will, is T cell therapy, where you can remove T cells, separate T cells from a tumor, from a patient, and expand those tumors. And that can be done without selection, or it can be selection against a certain antigen, and then reinfusing those therapies, those T cells, back to the patient. The advantages of that are that you're expanding T cells against a target that exists already, and it can be a very effective therapy. The limitations are that it requires a very specialized place, and it requires a conditioning regimen, which can be tough to do. Vaccines historically have not been very successful for the treatment of cancer, and part of the reason for that is the vaccines are targeting a certain antigen that may be present in different patients. It's not patient specific, so it may not be the right target. And so those have not been very successful. However, a different type of vaccine, such as a drug called T-VEC, which was just approved for melanoma, actually involves intratumoral injection of this virus, which has been inactivated, so it only selectively replicates within tumor cells, and then it causes the tumor cells to basically burst, and those are the patient's own antigens being released. And it's also engineered to secrete GM-CSF, which leads to dendritic cells being attracted. So conceptually, it's really a unique vaccine in that it's not a peptide-based vaccine, but it's releasing the patient's own tumor antigens. Now, the areas that we are most interested in cancer right now are really different ways of either releasing the brakes on the T cells or putting the foot on the accelerator of T cells. And the way that you can release the brakes is with PD-1, PD-L1 antibodies or CTLA-4 antibodies. And what those do is they block the negative signal between tumor and T cells, so the T cells can activate, expand, and destroy tumors. The other way that you can manipulate the T cells is by putting your foot in the accelerator, and that can be done through agonist antibodies, which are in development now, such as OX40 or CD137, and those are in clinical trials. And so different combinations of these types of approaches are really, I think, going to move the field forward in terms of immunotherapy. You know, the first experience with combination immunotherapy with different immune checkpoint inhibitors was CTLA-4 and PD-1, the combination of ipilimumab and nivolumab, which was also just approved this year for melanoma, showing superiority to one immunotherapy on its own for the treatment of melanoma.